Hello, my name is Austin Sumner, and I am the Medical Director of Occupational Medicine at the UVM Health Network, Central Vermont Medical Center. Today, I will be talking about work-related concussion, which is an emerging epidemic of cognitive disability. In terms of disclosures and disclaimers, I have no actual or potential conflicts of interest in relation to this presentation. However, I do actively treat patients with concussion, and I do perform independent medical exams. This presentation is made for general education purposes and is provided as is without warranty of any kind. All opinions expressed are those solely of the speaker. Today, I hope to cover some definitions and trends of concussion, review mechanism of injury, talk about both acute and chronic symptoms, discuss treatment options, return to work, and describe difficult concepts including misattribution, depression, anxiety, neuropsychologic testing, as well as cognitive functional capacity evaluation. Concussion is also known as a mild traumatic brain injury, defined as a head injury that temporarily affects brain function. Diagnosis requires less than 30 minutes of loss of consciousness. Memory loss should be less than 24 hours before or after the event, and the Glasgow Coma Scale should be between 13 and 15, and most commonly it is just 15 without any demonstrated impacts on the coma scale. Neuroimaging studies are usually normal. Post-concussion syndrome is a diagnosis that may be made when symptoms result from concussion that last more than 3 months. Symptoms may continue for weeks, months, and even years after concussion. 15% of individuals with a history of a single concussion go on to develop persistent symptoms. Some signs and symptoms consistent with post-concussive syndrome include noise sensitivity, problems concentrating, difficulties with attention and memory, feeling irritable, depressed, or anxious. These can all be attributed to a post-concussive syndrome. This slide reflects CDC-related data starting in 2006 through 2014. What I would do is bring your attention to the blue line. It's described as emergency department visits. And what we've seen over this 10-year period is that there has been a 53% increase in emergency room visits related to concussion. It does appear to be growing in prevalence. I will discuss the mechanisms of action related with concussion, and there are four primary mechanisms of injury. One is just direct contact force. There is acceleration, deacceleration, rotational force, and blast forces. Blast forces are often experienced by military personnel and can be a prominent source of concussion. This diagram here gives you an idea of what an acceleration, deacceleration trauma would do in terms of the brain. Acceleration and deacceleration is when the head is moving forward, comes to a stop, but the brain is still moving. In this mechanism, the brain can strike the front of the skull as well as the back of the skull. I do want to point out the areas that can be damaged really include the frontal lobes, as well as the temporal lobes and the basal portions of the brain and the brain stem. Blow and counterblow force is the concept where the brain injury occurs on the opposite side of the brain from where it was actually struck. When the skull is struck by a solid implement, it provides immediate damage at its point of contact, but it does also cause the brain to float forward and strike the other portion or the other side of the brain from the injury. In looking at this diagram, you can get a visual representation of additional places in the brain that may be injured in the presence of a mild traumatic brain injury. The following list includes acute symptoms. These include headache, dizziness, trouble thinking or concentrating, nausea, blurred vision, sleep disturbance, mood changes, and impaired balance. What I do want to bring your attention to with this list is which of these symptoms really have objective and quantifiable information that can be found on physical exam. That is most specifically, blurred vision can truly be assessed for a quantitative value as to how impacted it is, and balance can also be assessed quite well acutely in clinic. Important details of history that should be collected acutely at the time of injury include history of previous headache or migraine, include collecting a history of anxiety, depression, or PTSD, as well as assessing for previous concussion. Learning disability is also important, as well as attention deficit and hyperactive disorder are important portions of the history that we really want to know early in the patient process so that we can prepare for any things that may contribute to prolonged symptoms. The following acute clinical findings should be documented. This is my wish list, as they are not always documented, but when someone is acutely assessed for concussion, their eyes should very carefully be examined, searching for convergence insufficiency. Convergence insufficiency is the process where someone cannot bring their eyes together and focus on a close point to their face. Instead, they tend to see double vision, and this is usually greater than 3 inches. A convergence insufficiency is easy to see clinically and should be documented. Saccades and nystagmus refer to non-smooth eye movements. You ask the patient to follow your finger, both in a horizontal and vertical planes, and you look for either quick phase or slow phase movements, but the most important aspect is that eye pursuits are not smooth, and this should be documented. Additionally, a 30-second single foot stand should be assessed. What we're looking for is when someone stands on their foot for 30 seconds, how many times do they either have to touch with their other foot or their hand? Ideally, if you all tried this now, you'd be able to stand for 30 seconds without difficulty. Someone with acute concussion really struggles with their balance, and they will frequently put their other foot down, or they'll reach out to the wall, and often they will do this multiple times within a 30-second period. In addition, heel-to-toe walk should be assessed. And I personally like to do a cognitive challenge while doing a heel-to-toe walk or other balance testing. What we see is when someone's balance and their cognition is tested at the same time, that they tend to do worse. So someone that could previously do a 30-second foot stand, if you ask them to say the months of the year in reverse order, then they will really struggle with that, a single leg foot stand, and tend to place the other foot down more frequently to regain their balance. I think it's important to acutely assess someone's walking gait, particularly how they go around a corner, depending on where their eyes are focused. Attention and memory testing is important. I test both acute memory as well as more long-term memory to assess this function. What follows now are symptoms of concussion that can be treated. Often we hear there is no effective treatment for concussion, and with this, I just don't agree. This list includes treatable conditions, including sleep disturbance, which we will go into further in a minute, headache, nausea, vomiting, convergence insufficiency, also accommodation insufficiency, the role of PTOT, speech language pathology, the role of exercise, assessing pituitary dysfunction, cognitive behavioral therapy for managing both anxiety, depression, sleep, and PTSD, as well as some treatment recommendations regarding return to work. As you may recall from the acceleration-deceleration graphic, the temporal and inferior regions of the brain are often impacted in the presence of head injury. These are the regions of the brain that really control sleep, lead to sleep initiation as well as sleep maintenance. If these areas become disturbed or injured, it can be associated with changes in biochemicals that really contribute to sleep, including melatonin, hypocretin, dopamine, and serotonin. There is a physiologic reason for why individuals have impaired sleep following concussion. It is important to recognize impaired sleep early so that it can be addressed, as impaired sleep does contribute to prolonged recovery. 40 to 65% of individuals with mild traumatic brain injuries report symptoms of insomnia. Repeat traumatic brain injuries are found to increase the likelihood of insomnia. There does not appear to be a relationship when a head injury is present between insomnia, gender, age, and educational status. Poor sleep was found to be significantly predictive of poorer post-concussion symptoms, mood, community integration, and cognitive ability at 1 year post-injury. Sleep can be described, or sleep disturbance can be described in a few different ways. One is just poor sleep quantity or sleep quality. There's also delayed onset sleep, there's nocturnal wakings, there's wakings too early and not feeling rested. So how do we treat sleep disturbance? First and foremost, I recommend sleep hygiene. This is the practice of maintaining consistent sleep-oriented practices. This means going to bed at a consistent time, waking up at a consistent time, and potentially limiting naps during the day. It also means only sleeping in the bed, not watching the television or reading, but going to bed with the intent to sleep. This is step number one. If sleep hygiene fails, I do think considering cognitive behavioral therapy to learn relaxation techniques and learn other barriers that may be contributing to sleep is worthwhile. My first go-to medication for individuals reporting sleep disturbance after concussion is melatonin. This is an over-the-counter product. There is some suggestion that following head injury, melatonin levels do drop, and it is an initial non-habit forming place to start, and if taken 30 minutes before bed, can improve sleep quality. After melatonin, particularly acutely, if someone really reports they are struggling to sleep, I do move on to medications like zolpidem, which is also called Ambien. I generally only give this for short periods of time, but I do feel that treating sleep acutely improves outcome and it's worthwhile doing. In the presence of headache and sleep disturbance, amitriptyline I find to be very effective at low doses. Regrettably, as the dose levels increase, generally above about 25 milligrams, people report increasing hangover effect and grogginess in the morning, which in the presence of concussion is not always a great choice. Additional options, particularly if depression is present, is trazodone and followed by benzodiazepines. Benzodiazepines do have the highest abuse potential, and so they are really the last choice to consider. In my clinical experience, post-traumatic headache is the most significant limiting step as it relates to return to work and normal life activities. A post-traumatic headache has been reported to occur in up to 90% of cases, and it generally begins at about 7 days after the concussion or after regaining consciousness. The textbooks say they really resolve in 3 months. That's not my observational clinical experience. Often they can persist for years. Indication for CT includes really an abnormal neurologic exam or progressive worsening of the headache. Generally, imaging is not helpful, although it is done to make sure that there is not another explanation. Post-traumatic headache also commonly resembles migraine, tension headache, and cervicogenic headache, as well as occipital neuralgia, and all of these things should really be considered in the differential. To differentiate post-traumatic headache, it is often associated with oculomotor disturbances. This includes blurred vision from your concordance insufficiency, difficulty reading from your accommodation insufficiency. It can be associated with some dizziness, some nausea, and some blurred vision. Indication for treatment. I will generally treat a post-concussive headache if it's really occurring 3 to 4 days per month, and it's really continuing 2 months post-injury. Pre-injury headache is a significant risk factor for post-treatment headache, which is why it's so important to collect that information initially so that you can make sure that there is adequate headache treatment. Treatment is largely empiric. Often, individuals with traumatic brain injury will respond to similar treatments that they responded to prior to their brain injury. To date, there are no randomized trials showing what class of medication is the most effective. The list of medications that are often used include NSAIDs, triptans, particularly if there's a migraine component, tricyclic antidepressants, such as the amitriptyline, as I reported, beta blockers, anti-epileptic drugs, calcium channel blockers, serotonin, norepinephrine reuptake inhibitors. And I do think a promising class of medications is the calcitonin gene-related peptide monoclonal antibodies. And this is medications like Aimovig or Emgality. In addition to direct medication that's ingested, additional treatments can include botulism toxin injections around the scalp, as well as a forehead TENS unit, better referred to as the Cephally device. There are also some vitamins that can be taken to help improve headache control, and this really includes riboflavin and magnesium. I do find post-traumatic headaches to be very difficult to treat and often have to try a number of different medicines before a successful treatment. I have been quite successful though with the Cephally device, which is the forehead's 10 unit. The nice thing about this is there are limited side effects. It is really just a single time purchase with periodic pad replacement, and it can be used for both prevention and for treatment. Nausea and vomiting is an acute symptom that people will often report. It is a significant impact on quality of life and really should be addressed early. The medication list that follows is really the strategy that I utilize, aldosterone, and I like the oral dissolving tablet as it tends to work fast and it doesn't tend to worsen any nausea. Promethazine and scopolamine are also choices, but trying to understand the basis of the nausea through whether there is an impact on the vestibular ocular system is important, as it could be that the concordant insufficiency or the accommodation insufficiency or other vestibular issues are really what are contributing to the nausea. Convergence insufficiency. This is a treatable condition and it is clearly observable. It is a means of following improvement in someone's clinical case as well. If it really persists, referral to neurooptometry can be very helpful. There are both computer and eye exercises that can be done to help reverse this. My initial go-to is generally referring someone to my neuro occupational therapist, and they will readily identify any eye findings. Exercises that can really help in particular are the Brock spring test. This is where you have 3 beads on a piece of string and you really try and make your eyes focus on each of the beads so that you don't experience double vision. Convergence insufficiency should be regularly monitored. Accommodation insufficiency isn't listed here. This is where you have trouble focusing up close. It is an important source of headache as well. The way I assess this is I will often ask someone to try and read some fine print and see how well they do. In the presence of accommodation insufficiency, I will generally refer to neurooptometry as well. The role of PT, OT, and speech language pathology. At my institution, we do have a multidisciplinary team approach to concussion, particularly work-related concussion. I do work very closely with my occupational therapy, my physical therapy, and my speech language pathology team, as well as a clinical psychologist. Often, my physical therapist will help identify acute autonomic system dysfunction. What we see in concussion is that when someone overexerts themselves, they do get an autonomic discharge, which really causes their blood pressure to do funny things and drop, and their heart rate to zoom up, and it brings back symptoms quite severely. It is a useful test. The Balky test or also the Buffalo exercise test are useful tests to assessing ongoing concussive symptoms. My occupational therapists tend to heavily work with eye issues and vestibular issues, and my speech language pathologists will often help when cognitive difficulties are present, particularly with attention and memory, and really teaching skills and strategies to overcome those difficulties. Pituitary dysfunction. This graphic here helps understand how the pituitary gland can become injured. The pituitary gland is a small gland on the basal part of the brain, and as you see, it is really encapsulated in bone. If the brain were to be jiggled, the front or the anterior pituitary can strike that bony casing and become damaged. This can contribute to some of the symptoms that we see in concussion, particularly those that have prolonged or longer presentation. It has been reported that pituitary dysfunction can occur in up to 15 to 20% of traumatic brain injury patients. There is no clear guidance as to when to order neuroendocrine labs. If someone has been admitted to the ICU for their head injury, it should generally be done before they leave hospital. Otherwise, generally waiting 6 to 12 months, although I tend to reserve this for individuals that are not really improving, things don't make sense, and I really just want to see if there's another medical explanation for why they haven't made the level of progress I would anticipate. The neuroendocrine labs that I focus on are those that are really controlled by the anterior pituitary gland and do include the thyroid stimulating hormone, a free T4, an insulin-like growth hormone, prolactin, luteinizing hormone, cortisol, follicular stimulating hormone, and testosterone in men, estradiol in women. I don't order pituitary function testing universally, although in the instances that I have not yet identified pituitary dysfunction related to concussion. However, I have made diagnoses like pituitary adenoma and other endocrine issues, and so it can be worthwhile and pointing out symptoms that really may not be due to the head injury itself. Return to work. This is the subject that we are all most interested in and continues to be one of the most challenging aspects of concussion, in my opinion. I do find that an individual suffering from concussion can be amongst the most challenging to get back to work, and I wish I had more pearls as to how this was done. In general, most workers return to work in 3 to 6 months after TBI, although that is not always my experience. I certainly have had individuals upwards of 3 to 4 years and still been unable to return to work. The textbooks say mild traumatic brain injury is not a significant risk factor for long-term disability. This isn't necessarily consistent with my observational data. However, that being said, early return to work is good. Rapid restoral of normal life activities is positive in concussion. Individuals should be returned as quickly as they can. For mild, they really say between 24 and 6 days. However, it is a judgment call. It really depends on the type of work the individual is doing as to how soon they can return and what the employer's policy is in regards to allowing light duty or at least reduced time at work. Some predictors of delayed return to work. Lower educational level is thought to be a reason. Nausea, vomiting on hospital admissions, extracranial injuries. These are injuries in addition to the head injury. Is a risk factor. If you've had multiple injuries, your return to work will not be as quick. Job independence and autonomy and independent decision-making actually makes a big difference. If you have the ability to control your work environment, you're often able to get back more quickly. Older age is a predictor of delayed return to work, where one study I've seen is individuals between 20 and 29 discontinue wage replacement more quickly than other groups. A significant predictor with any return to work relationship, though, is when there is a breakdown in a relationship between the employer and the employee. So pre-injury risk factors, as you see, this does contradict itself a little bit from my previous slide with age. Although age is not supposed to significantly be a risk factor, the younger you are, the more quickly you tend to return. A non-predictor is female sex, emotional problems, physical comorbidities, prior head injury, no loss of consciousness, and post-traumatic amnesia have not been found to be predictors of delayed return to work. Misattribution. This is really an important concept for anyone who does concussion work to understand. And this is erroneously attributing any perceived difficulties to the injury. This is something that I frequently speak with my team about, to really say, is that presentation due to concussion, or is there some other better explanation, anxiety, depression, other psychiatric condition that is not really a direct result of the head injury itself? It's the tendency to attribute common current symptoms and health concerns to the past concussion. What this means is you're really blaming the concussion for everything that's wrong with you. There is also this tendency to underestimate pre-injury problems and overestimate pre-injury health. So generally, we think that we're really better than we were. When we really survey non-concussed groups, we find that concussed group endorses far fewer symptoms pre-injury than the base rate by a healthy group. So there is this perceived the perception that they were in better health than they really were, and it's the tendency to then blame the concussion for all of their symptoms, which may have been there before. All of us are entitled to have a brain fart now and again, where we forget somebody's name at a party, or we forget why we walked into the room. It's not because we all had concussion. Depression. Depression is actually remarkably common in post-concussive individuals. It's reported in 12 to 44% of individuals will have some degree of depression in the first 3 months. This is partly due to the portions of the brain that can be injured in concussion, are portions of the brain that can lead to depression. Now, this depression can be further contributed to when you are feeling cognitively compromised. It can shake your identity. Psychological distress can create further cognitive compromise. When you're anxious about not being able to say something correctly, it can often make it seem even worse than it is. Cognitive symptoms are also a frequent cause of frustration, anxiety, and do result in avoidance type behavior, where people don't want to interact with others or go to the store because they think they're going to forget or become frustrated, so that they tend to avoid activities. Anxiety, again, is a major contributor to symptoms of concussion and can often be confused because of the overlap with concussive symptoms. Anxiety, though, creates fear, avoidance, and worry in response to environmental stimuli. There is the fear of being re-injured. There is the fear of perceived weakness. There is the fear of achieving a desired role, fear of isolation, fear of financial instability. When you're out of work and you're on workers' comp, it can be very stressful and a source of anxiety, as well as just the portions of the brain that are injured. Anxiety can be further aggravated by employers who are growing impatient with the length of recovery, or external pressures such as the work comp carrier or the adjuster, creating additional anxiety or stress. Stress is not helpful in concussion recovery. Minimizing stress and anxiety when someone is resolving or post-concussion is really very important, as creating unnecessary stress and anxiety can really prolong symptoms. And it is one thing that is fairly easy to do, is try and limit unnecessary stress. Iatrogenic disability. This is also, I think, an important concept for us all to understand. And this is the disability caused by the medical examination or treatment. If an individual goes into the emergency room, even though they've had a very mild injury, and they're told, oh, they've got this concussion and that it's terrible, and they do some internet research, it's really the act of the medical community disabling someone. Rest and gradual return to activity based on symptoms is okay, but prolonged removal from normal life activities may contribute to the development of post-concussive syndrome, as well as lead to the lack of improvement. It is really for this reason that we need to try and regularly get individuals back to work to see how they will do, and not create additional disability just because of the medical community's inability to get somebody back to work. Cognitive behavioral therapy. We did speak briefly about cognitive behavioral therapy as it relates to sleep hygiene. There is reasonable evidence, though, that education and reassurance are highly effective at reducing post-concussive symptoms. One study found that as little as one psychoeducational session can be helpful in preventing post-concussive syndrome. Supportive reassurance during therapeutic sessions, as well as education about symptoms, expected recovery, appropriate attribution of symptoms to benign etiologies, improved coping skills, and early identification of anxiety, depression, PTSD are really very important. I would therefore strongly support the utilization of a clinical psychologist that is familiar with the workers' compensation system, because this can really be very helpful. Cognitive behavioral therapy can really be very helpful early. Once someone has really gone on to progress, that their anxiety, depression, PTSD is out of control, it gets much more difficult. So I would recommend early evaluation by someone knowledgeable in cognitive behavioral therapy. Exercise. I cannot speak of the importance of exercise enough for those that have had brain injury. One acute effect of concussion is exercise intolerance, as we spoke about the autonomic instability that can occur acutely. This is a means of following somebody's progression. However, if someone will regularly exercise, typically to 50 to 80% of their age predicted heart rate, they will have improved outcomes and will have a speedier recovery. When a patient can exercise to exhaustion without exacerbation of headache or other symptoms, they are no longer having physiologic evidence of concussion. That's why doing regular exercise testing is important, because you can actually identify when someone's acute physiologic effects from concussion have resolved. The important thing is that when exercising, you want to exercise to a sub-symptom threshold. It should be aerobic activity, and there is evidence that it speeds recovery. However, if someone exercises too hard, i.e. they are exceeding 70% of their age predicted heart rate, then they may experience more symptoms and they may actually have a setback. And so generally, I just encourage people to walk daily for about 30 minutes and to rest as needed. And it does seem to really help their outcome. Rest is not necessarily the best medicine. Neuropsychologic testing is a means to try and have quantitative data regarding the integrity of brain-related function. What I generally use neuropsychologic testing for is to identify any inconsistencies in presentation or to identify other plausible explanations of someone's symptoms, get a better description of their anxiety, their depression, their PTSD symptoms. But really, I'm looking for inconsistencies so that I know that things really make sense and there is not some self-limiting that's taking place with someone's recovery. The role of neuropsychologic assessment, some suggest getting early and late, 3 months and 12 months, so that you can really compare. There is no fixed standards. In my treating region, it often takes 6 months just to get a test, which is a very long time to wait. And I also have to ask whether it changes treatment. And so, although I do order them, I don't get them universally. I do find cognitive functional capacity evaluations to actually be a little bit more helpful when it comes to return to work planning than neuropsychologic testing period. Neuropsychologic testing, I find, can be helpful for really determining an impairment due to intention and memory loss. But I find the cognitive functional capacity evaluation, which is similar to a functional capacity evaluation, just with an additional focus on cognitive demands, can be really helpful when it relates to trying to get someone back to work. This will really give a sense of how long they can do certain activities and can really point out whether how someone can follow directions, whether they're able to use the screen time, and it can really provide some useful direction. And I have been increasingly utilizing the cognitive functional capacity evaluation, particularly for individuals that have been suffering from concussion for long periods of time, and I would generally say it about a year. So in conclusion, some brain rest is okay, but generally we want to return to activities as quickly as we can. Gradual return to work is appropriate as long as it's not triggering symptoms. I do think that there's an important role for cognitive behavioral therapy and really doing this early. I would also strongly encourage treatment of insomnia early. I would encourage exercise early. I would get on headache treatment early. These are all modifiable conditions as it relates to outcome, and early treatment is effective, and it should really be paid attention to. Thank you very much. I am delighted to take some questions, and please watch your head. Thank you.